Good morning. Welcome to the presentation. Today I'll be talking about traumatic hyphema with low intraocular pressure, secondary to a cyclodialysis cleft. So we had this patient who came to the clinic, a 42-year-old male, who presented with pain and blurry vision on the right eye after he sustained trauma to the right eye with a blunt object, a pipe. That was on 6th of May 2020. He had been treated elsewhere and put on ciprofloxacin, dexamethasone, timolol, and atropine eye drops. The visual acuity was hand movement on the right eye and 6/6 on the left eye. The intraocular pressure on the right eye was 10 and the left eye was 20. The cornea was hazy with some Descemet's folds and a few clots in the anterior chamber. The lens had a few opacities. The fundus had a hazy view. The left eye was normal. An ultrasound of the right eye was done, which showed no vitreous hemorrhage and no retinal detachment. An impression of traumatic hyphema of the right eye after a blunt trauma was made. The timolol was stopped, and he continued on the ciprofloxacin, dexamethasone, and the atropine. 2 weeks later, he was reviewed, and the vision had slightly improved to counting fingers at 1 meter. The pressure had dropped down on the right eye to 1. The cornea was clear. The anterior chamber had no hyphema, the lens had a cataract, and the fundus could not be visualized. Gonioscopy of the right eye revealed a cyclodialysis cleft in the superior quadrant. An impression of cyclodialysis cleft of the right eye post-trauma was made. On 26th of May, he was taken to theater for cyclodialysis cleft repair. Intraoperatively, the examination on gonioscopy revealed a 120 degrees cyclodialysis cleft extending in the superior and superinasal quadrant. Repair of the cleft was done with nylon 10-0 and the flap of the sclera was sutured with Vicryl 10-0. The following day, the pressure had risen to 8 and the anterior chamber had some mild hyphema. He was put on 2-hourly dexamethasone, antibiotic combination, and atropine. 2 weeks later, the vision was counting fingers at 1 meter. The intraocular pressure on the right eye was 3. Gonioscopy revealed a closed cleft superiorly and nasally. It was open to the ciliary body band inferiorly and in the temporal quadrant. In the right eye, the cornea was clear. The anterior chamber had no hyphema, and the lens had a cataract. The atropine was stopped and the steroid was reduced to 4-hourly. On 1st of July, the vision had improved to 636 and the pressure was 8. He continued with the steroid antibiotic combination. The cornea was clear, the lens had a cataract. On 5th of August, the vision was counting fingers at 2 millimeters. The pressure had risen to 26 millimeters of mercury and the lens had a cataract. He continued the steroid antibiotic and anti-glaucoma treatment was started. That is a timolol latanoprost combination. On 11th of August, he underwent cataract surgery on the right eye. On inserting the intraocular lens, the sulcus seemed tilted. On 26th of August, the vision improved to 660. The intraocular pressure was 21. The cornea was clear. The intraocular lens was partly in the bag and partly in the sulcus. And the treatment was changed to bimatoprost timolol on the right eye, and brimonidine was also added. The steroid antibiotic was continued. On 1st of October, the vision was 660 and it improved to 65 on a sphere of -1 and a cylinder of -2.25 at 10. The intraocular pressure was 12. The cornea was clear. The intraocular lens had some optic capture superiorly. On fundoscopy, the cap to disc ratio was 0.3. Gonioscopy on the right eye revealed peripheral anterior synechia in all quadrants. The steroid antibiotic was tapered. He continued the bimatoprost timolol combination. He continued the brimonidine, and he was given the spectacles and booked for a trabeculectomy with or without intraocular lens repositioning. So in the discussion, we'll discuss what is a cyclodialysis cleft, and this occurs when the ciliary body detaches from the sclera spur. The causes are mainly trauma, ocular surgery, and glaucoma surgery, either intentional or as a complication. It creates a free communication between the anterior chamber and the suprachoroidal space, and this enhances the scleral outflow. Aqueous production may or may not be reduced, and there's no relationship between the size of the cleft and the degree of hypotomy. It presents with low intraocular pressure. If the cleft closes suddenly, the intraocular pressure rises to high levels. If it is reopened with a meiotic, the intraocular pressure falls rapidly. Diagnosis is made by gonioscopy. The patient is given pilocarpine to open the cleft maximally. Compression gonioscopy can be done if the anterior chamber is shallow. If this can be deepened with viscoelastic, and the number, extent, and locations of cleft is determined. Ultrasound biomicroscopy also reveals the cyclodialysis cleft, and this can also be revealed by surgical exploration. The first image shows a gonioscopic view of the cleft, which is seen, and this occurs after the detachment of the cleft from the scleral spur. A narrow space is seen in between the two features. The second image shows an ultrasound biomicroscopic image of the cleft having detached from the scleral spur, and the anterior chamber is communicating freely with the suprachoroidal space. Treatment can be conservative. One can observe for about 6 to 8 weeks while giving atropine to enhance apposition of the ciliary body to the sclera. Steroids can be minimized or discontinued to enhance inflammation. Laser treatment can be used, that is argon laser, cryotherapy, transscleral diode laser, and laser photocoagulation. Surgical treatment is by ciliary body suturing. Repair of the cleft with surgery is done by creating a corneal keratotomy, and one arm of the needle passes through the keratotomy, touches the peripheral iris, and exits beneath the scleral flap. The procedure is repeated with the second arm of the suture and tied. Alternatively, a flap can be created, or a scleral flap can be created, and the initial suturing is done from the scleral flap, touches the peripheral iris, and exits beneath the other part below the scleral flap. So the image shows the insertion of the needle, and then the second picture, the needle goes, touches the iris or catches the iris, peripheral iris, and comes out, and the procedure is done on the other side, and this is tied. The third image shows a gonioscopic view of the cleft having been attached to the sclera. This is an image of the cleft before and after the repair, where initially in the first image there's a free communication between the anterior chamber and the suprachoroidal space. After cleft repair, the space closes and the ciliary body is attached to the sclera. Thank you.